Well, Martin will talk about patient selection and treatment algorithm for the covered stents in iliac artery. Martin?
Hello, everybody. Thank you very much for the kind invitation. I really enjoyed your discussion in this really nice case from Italy. It was very special and a very good result. We have to deal with this in special kinds. So my comment to this, maybe the Sapera stent is also a good thing, but also maybe you know the new Rensa stent is also a woven stent, and maybe it's a good issue in that kind next to the Sapera stent. But we go further with the Iliacs. Maybe the technique can conclude the Italy colleagues. Is that possible?
Yes, we can see you, we can hear you, we can have the presentation.
Yeah, but I hear the colleagues from Italy in my thing.
Martin is not from Italy, he's from Spain, sorry.
Oh, from Spain, sorry. So I have no disclosures. I will go on further. For iliac treatment, it's very important what kind of diagnostic you have. In my opinion, the most common and the best one is CTA scan. You see the calcification, you see the thrombus material, and you see all the kinds you are interested in. You see also a good view of maybe an instant restenosis, and you have a good opportunity to measure these kinds of things. So second question, is it possible to delete or unmute the colleagues? Thanks. So go further with the MRI. You see maybe a good view of these vessels, but also you can't imagine, is it as a stent or is it a delay in the angiography? So in my opinion, it's not the best way to go for MRI. Furthermore, diagnostic, we all use the ultrasound is a good advice for soft plaque and thrombus material, calcification. And what we think about that one is in further step, the task classification. And now I want to talk about the type classifications of type C and D. And these are the most common in the iliac stents and in the bifurcation or in the occlusive diseases in the aortic occlusive disease. So when we consider our conclusion, so we have to take our times. Where's the location? Is it in the common femoral artery? Is it in the external iliac artery, in the common iliac artery, or is it the bifurcation that is also located what we have to treat it? The stenosis grade is also dependent on the type classification or on the task classification, mid-severe, or is it a total occlusion? And on what kind of length did we have? Is it in calcification? Is it in thrombus? Is it a multi-level stenosis? Or is it in mixed morphology, what we have to deal with it? And also, did we treat an instant occlusion in that kind of area? Or have we all a new occlusion? Next step for us is the access. So we go for a crossover, or we have to do a cut down in the groin, in the antegrade or in the retrograde approach, or we have to deal with the brachial approach or an up and over. So this is the things we have to look for the access, and this is the first important steps when we look at our CTA scan or in our advice to go for the best treatment. Second step, what kind of sheets we have to in our opportunity to deal with it. We have in this most common 6 French up to 11 French, maybe to go with an aortic stent where we need a large sheet. Then there is an opportunity for steerable sheets, straights or multi-purpose sheets. And it's very important what kind of sheets we have to that one, because maybe we have to protect our stents in the kind of protecting sheet device to place the stent in the right area. So what kind of wires we need to cross the sections or to cross the CTOs? Sorry, can we delete or close or unmute the Spain's colleagues? It's very annoying for me to speak against them. So we start mostly with an 85 wire and sometimes with an 18 wire. And this is most important with the tip load and the tip configuration and also the visibility for these wires. Sometimes we go for a loop technique or direct puncture of the occlusion, and we mostly go for thrill and frill. So, and always we use a torque device for better crossing the CTO in that way. We also use crossing support catheters. They are also available in different different measurements, 85, 18, and 14. And sometimes we use also a support PTA with some stiffness and lower profile, and sometimes in different kind, mostly BTK. There are small lumens available also for coronaria. They are also available in straight or angled configurations, very important to cross these lesions. We all know these CAP classifications, C-top classifications. They are also important to go intimal or subintimal. And here their classification is the most important in type 2. We have more than 86% to deal with that one. And this is very important to go maybe for intimal or subintimal crossing these lesions. And this is the second step to go with the best opportunity to stent or to treat them with that one. So all comes to a good crossing, in my opinion, when we go intimal or subintimal. One explanation to that one is also the safari technique for go subintimal with a balloon on and a wire to cross them and then to fix a new lumen for these subintimal lesions. In my opinion, it doesn't work very well, so I go further with other kinds of crossing devices, and one of the best one, in my opinion, is a needle system. Here I can recommend the BBAC system with the crossing device with a needle. There are also other kind of crossing devices. Here you see or find a QR code for the endovascular today, and when you put in the crossing devices, you find 44 products only for crossing devices in kind of that one. So in my opinion, one of the best one is a needle system, and don't look too longer for that one. So go further and try that one. So the most problem is, in my opinion, the re-entry and the entry in this kind of lesions and crossing failures. We have 20 to 40 failures, and we have to deal with them. This is one example. You see the needle system with a small tip. It's like an L, and then you find the wire, and it's go up and down with a snare. Here you find it in the right lumen, and then we go further through the bifurcation, and we have an up and down wire for the next step to go further to treat the lesion. This is one in the bifurcation. You see on the one side a small catheter, crossing catheter, and on the other side you see here also the system with the needle system. And then we position it here like a large L, and then the needle is not very to see very good, and then the wire comes through the laminas. And after that, we can complete our treatment. This is one of the IVUS integrated needle system. It's called Pioneer Plus from Philips. And here you can see the right and the false lumen. And it is possible to go with the needle in the right lumen to puncture the right lumen and to cross the false lumen. And it's very easy to see where you have to go with your needle system. So I really recommend these both systems with the needle system because it saves you so much time for a treatment in this area. So what kind of stents we use in these IOD lesions? The COBAS trial has already shown in the year of 26 that the normal balloon stents is not the best one in that way. We see that the covered stents have a better patency also in tests C and D lesions, and it's a very better in that way to use them instead of bare metal stents. So in kind of test C and D lesions, we go for covered stents in that way. So the position of these stents is very important, and we see when we treat it in the bifurcation, the kissing stent system, but it is very important to go for this configuration, and you see when we use a kissing stent, it is a high indemnification risk for restenosis and thrombosis. And why is that one? So there is a configuration in geometrical system from Peter Gewörde. He also invited to the CEREP system. And what you see is when you use a kissing stent instead of a CEREP stent, there is a radial mismatch in that one. And with the CEREP system, you see that there's not this radial mismatch for these kind of thrombus building. And that is the reason when we go or when we treat the normal bare metal stent or covered stents that we use in that area for the bifurcation, the CEREP system. So this is one here compared to normal stent on the right side, it's called A, the normal kissing stent, then a normal kissing stent with covered stents, and a normal CEREP system, but the Iliac stents, they look also 1.5 centimeter inside the aortic stents, and the last one is aortic stent with the bifurcation iliac stents, a little bit more than a half in the aortic stent. And the best way to see what radial mismatch is in that one is here the CEREP system with the lowest radial mismatch. So what we found in that way is the normal stents has a higher radial mismatch instead of the normal covered stents, and the best one is the CEREP system to treat them with the best way with the radial mismatch. So we see that also in a in vivo geometry kissing stent versus the normal CEREP system, and the long terms with the first final results from Peter Gewörde, and the long term had a patency, primary patency up to 90% in 1 year and 82 in 2 years, with a primary and secondary patency for 95% in 1 year and also in 2 years. So, and that one is the conclusion that the CEREP technique is very feasible and an alternative to open surgical reconstruction in aortic bifurcation or complex occlusive disease. This is one case I want to present, which I treated last week. It was a normal occlusion, very easy to see that the occlusion of the common femoral or iliac external, the internal was also occluded in the complete occlusion of the common femoral, of the iliac common artery. And first step was we open in the groin here on the right side and go back with a late thrombectomy was the first step. But it was not possible to cross in the area of the bifurcation or in the area of the infra-aortic. And what we see here, that the small wire also crossed on the aortic subintimal, and it was not possible to cross it that way. And here you see it's getting worse and worse. And you see a pigtail on the left side. And what in that time I want to decide is go for a needle system or try a second step to go further. And what I decided was to go with a steerable sheet for more pushability instead of maybe a pigtail catheter or other catheters, because they are too soft in that area. Or you come from further up to the approach from the brachial approach, but it is a long way, and you save more time to go with the maybe with the steerable sheet. And it was possible to lock the sheet in that ankle and go further with an 84 wire to cross the dissection and also the occlusion. And then we had a through and through wire and go further with our next steps. It was to pre-dilatate both sides of the iliacs. And but what we see is that there was a small lumen in the area of the infrarenal aorta. And what we go further is to go with the Serap technique to place an aortic stent to flare it in the proximal part and go further with the iliac stents. And it was a good result. What we further start with a normal iliac stent on the right side ends up to the Serap technique. So we have to prepare to deal with that cases, in my opinion. Other nice cases was a highly dissected part with some great or big stenosis in the infrarenal aortic. You see here also a Serap technique, or a coral reef aortic. It's also treated with Serap technique in that way. And you also have the opportunity to reconstruct a further kissing stand when they are occluded with the Serap technique to go further in that stepway further into the aortic way. So let me conclude. Covered stents in TASC lesions is the best way to treat these lesions, using re-entry devices like the needle system or also a steerable sheet. Take your time for preparation, what kind of gear we have, what kind of access we need from the arm, or to go further with some other wire techniques. And Serap technique is, in my opinion, a good opportunity for open surgery in IOD lesions, and you can also treat it percutaneously in that area. Thank you very much for your attention and for this kind invitation to talk about this Serap technique.
Thank you very much, Martin. For the sake of time, we can have one comment if anybody has comment or question for Martin.
Thank you, Martin, for this nice presentation. For a Serap technique, we do it really if we have like a disease aorta, but if you have complete occlusion, we notice that if you Serap technique have high chance of embolization because the plaque has to go somewhere. So we prefer to use too long stent. If you have stenosis, I agree, but if you have a full aorta full of atheroma, and you do a Serap technique and put a large aortic stent, this plaque has to go up or down. So what do you think? In this scenario, we prefer to use too long, stent instead of Serap technique.
Yeah, it depends what kind of, what you have to deal with it. So it's most important to show or to look first what kind of conclusion or occlusion do you have. It's a thrombus or it's a highly calcification aortic, like a porcelain stenosis. And I have a colleague, he was treated at Serap with a highly calcification, and it was also ruptured on that area. And the patient was open surgical treatment, but he was die instead of this kind of first steps of the Serap technique, mostly. But what you said or what you mentioned is when you have the opportunity to save, or when there's thrombus is getting higher to the renal arteries, you have to prepare them like a chimney technique in that way. And you can also use the chimney technique in kind of Serap. So Serap plus chimney is maybe a good way to deal with these kind of highly thrombus or highly occluded areas of IOD lesions. In my opinion, it's very complex, but you can do this. Yeah, maybe it's the best way to deal with that one in Serap technique with chimney.
Okay, one short question كده from Professor Khaled.
Thank you for this nice case, but in my opinion, it's best to start from the brachial approach in case of chronic total occlusion of the proximal iliac artery, not to go from the femoral artery, as it may make a dissection till the dissection in the aorta till the renal artery. It is very dangerous. So if you go from the brachial approach, I think it will be better.
Dr. Khalid is asking if about the brachial axis to come from the above. Is it better than coming from the femoral?
Yeah, it's also possible, but you don't. Sometimes you need this time, but you also remember that we have a highly stroke recommendation of 2% of strokes in that area. But you can do this. It's also better to go intimal in that area, and that also. But you don't have. You need a large size of sheets, maybe 90 centimeters. And it takes a little bit more time. But also, we all take these learning curves. We all do that one way. Now I go further with this needle system. It goes very easy and saves your time, and also the time for the radiation, and also the time for the patient. In my opinion, you can go further with these needle systems, but you also can do maybe step 1 on the brachial part, and then second one. Go to the needle system. It's up to go. It's your choice.
Thank you. One last short question from Professor Hisham Sharaf.
Thank you, Matt, for this nice presentation. I asking you're using the syrup technique for aortoiliac occlusion disease as a first choice or as a bailout technique when the patient is unfit for surgery, because the durability of this technique is less than the surgical aortobiform. So you're using it as the first choice for you or for selected patients?
Yeah, it's a good question. First, I go endovascular in selected patients, but instead of that, I will recommend it. I also go for kissing stents. I don't do that in all of these patients. So if we have a good anatomically, I go for a kissing stent, and I look further instead of we go for syrup. And when we have opportunity to go for a syrup,